strabismus. And now Dr. Resmi from Pediatric Ophthalmology Clinic, Chaitanya, Trivandrum, she is talking on two things. One is the essential principles in the management of patent strabismus, and also the management of patent strabismus, tackling the obliques is also an important thing. So she will be dealing with tackling the obliques also in her talk. And over to Dr. Resmi for her two talks, which she has combined as one.
Good morning. First of all, let me thank Sahasrama sir and KSOS for giving me this opportunity. I have combined my two talks as a single one. So let's see what is the principle in the management of patent strabismus. Patent strabismus is not rare when one looks for it. It is difficult to manage than pure horizontal strabismus. A and B pattern will be seen in 15 to 25% of the horizontal strabismus. So the basic principle is, when you are planning for a correction, you have to divide the patient into two, those with oblique dysfunction and those without, and select a surgery to reduce the horizontal deviation in primary position and also to minimize the AV incompetency. The horizontal muscle shift works well when there is no oblique dysfunction. Primary and reading positions are functionally most important, and the results of the surgery can be unpredictable. So the patient workup, as Dr. Chaitanya has already told, abnormal head postures, measurement of deviation in up gaze and down gaze, and also in all 9 gazes. The overaction and adduction, that is very important because you are planning surgery according to it, that is inferior oblique overaction or superior oblique overaction, that is the overaction and adduction, the hypo or hyper should be evaluated. Torsion, which can be tested by double Maddox rod or by disc picture, that is more reliable criteria than an inferior version testing in case of overaction of the obliques. And orbital imaging is a must before surgical planning in case of craniofacial anomalies. Coming to the management part, as we all know, the first thing is to correct the refractory error, if any, and correction of the amblyopia. Just because you have diagnosed a AV pattern doesn't mean you need to do surgical correction in all the cases. It needs to be done only if significant or symptomatic in the direction of largest deviation. So what are the indications for surgery? To improve and maintain the binocular single vision, they correct the abnormal head posture and motor alignment. The surgical management of AP pattern can be divided into two, with oblique dysfunction and without oblique dysfunction. First, we will be dealing with without oblique dysfunction. The horizontal muscle shift is a thing that you do when there is no oblique overaction. The maximum offset is 7 mm, and you move the muscle in the direction you wish to weaken them. As we can see in the acronym MAIL, medial rectus should always go towards the apex or closed end, and lateral rectus should always go to the empty space, that is the open end. So horizontal muscle shift was first described by Knapp. Is it easy to perform? Then you do oblique muscle surgery. Useful for smaller pattern, you shift half to one tendon width, and half tendon width shift will correct around 15 to 20 prism diopters. You can combine it along with the recessions or resections. The amount of recession and resection will depend upon the deviation in the primary case. The only problem is it can sometimes induce torsion if you are done in unilateral cases. In case of A esotropia, if you are planning for a bimedial recession, you shift the medial rectus upward. And in case of B esotropia, you shift the medial rectus downward. If you are planning for a recession resection, in case of A pattern exotropia, the lateral rectus will be pushed down and medial rectus pushed up, and in B pattern exotropia, the lateral rectus will be shifted up and medial rectus will be shifted down. Then another procedure is the slanted recession, which was described by Boyd in 1971. In case of B esotropia, the slanting recession with greater recession of the inferior muscle insertion of medial rectus, and in A esotropia, more recession of the upper end. So wherever you want to more weakening, you recess, that part will be kept posteriorly. The vertical rectal surgery with horizontal displacement of insertion, that is superior and inferior rectus shifted medially or laterally, it was described by Miller. It affects the adducting force of recti but not routinely done. Now coming to my second part, that is tackling of the obliques, especially in cases of AV pattern. As we all know, the inferior oblique overaction usually causes a V pattern, and a superior oblique overaction causes an A pattern. And they coming first to the inferior oblique surgery. The common weakening procedures are myotomy or myectomy, recession, anterecession, anteronasal transposition, and extirpation and denervation. Here myotomy and extirpation and denervation are not routinely done. The inferior oblique surgery, how will you approach it? Infratemporal infratemporal incision is made, and from 8 millimeter from the limbus, you make a cut in the conjunctiva. Perpendicular incisions are made in the tenons to expose the bare sclera, as you can see by careful dissection, and then the obliques are visible. You hook under direct visualization. Coming to the myectomy, after hooking the muscle, you take 8 to 10 millimeter of the muscle part is removed. You clamp it, you cut the muscle part, cauterize and leave it. Large V pattern corrects about 40 prism diopter when done bilaterally. In case of unilateral superior oblique palsy, it corrects around 15 prism diopters of hypertropia. The inferior oblique recessions, various recessions are described. Fink recession is 6 millimeter posterior and lateral to lateral rectus. The new insertion is kept there. Park is 8 millimeter recession where the inferior oblique is placed 3 millimeter behind and 2 millimeter lateral to the lateral part of inferior rectus. Eliot and Nankin has described different levels of recessions at the level of inferior rectus or anterior to it. And antero positioning is mainly indicated in case of DVD along with an inferior oblique overaction. This is a video showing the inferior oblique recession. We have hooked the muscle just I have shown before. You clamp the muscle close to the insertion. Now the muscle is clamped after hooking close to the insertion, and you cut the muscle and secure and clamp before taking the sutures. Usually in horizontal strabismus, you place the sutures and then you cut. Because the insertion comes close to the macula, it is always safe to cut the muscle, keep in the clamp, and then you place the sutures. Now the two sutures are placed 6-0 vicryl on either side, just like you place in a horizontal muscle surgeries. By doing this, you will avoid injury to the surrounding structures. Your muscle is secured in sutures, and you mark the position, that is 3 millimeter behind and 2 millimeter lateral. In the sclera, marking is made. And you take the scleral bites, and the muscle is secured in position. Always before cutting, you make sure that you hook the lateral rectus as well as the inferior rectus, and you visualize the procedures and do. Now the muscle is secured in position and you tighten the sutures. After tightening, the conjunctiva can be closed with 8-0 interrupted sutures or continuous sutures. Now the various graded recessions, as the muscles are placed anteriorly, you get a more weakening effect, and various other procedures like antero-nasal transposition and nasal transposition has also been described. Inferior oblique anterization is done when you are seen along with DVD. The muscle is placed anterior to inferior rectus. This is a postoperative picture of a child who had a DVD along with an inferior oblique overaction and a large V pattern. Inferior oblique advancement has also been described for A pattern esotropia. Here you are disinserting the inferior oblique and passing it under the lateral rectus and attaches to sclera 2 to 3 millimeter superior and 8 millimeter posterior to the lateral rectus. Now coming to the superior oblique surgeries. Two types of surgery are there for the V pattern. You do, in case of superior oblique palsy, you can do a superior oblique tuck, and in A pattern with the superior oblique overaction, you do a weakening procedures. Superior oblique tenotomies you do in case of A pattern will correct the large A patterns. Around 25 to 45 prism diopters are corrected, and tenotomy close to the origin will have more weakening effect, and there is no significant alteration in the primary position. Posterior tenectomy of the superior oblique, the posterior fibers are cut where the anterior fibers which are involved with torsion are preserved. It has a weakened abducting function, and it has less chance of producing a superior oblique palsy, and chances of but undercorrection is there. This is a video by my friend Dr. Soumya from Shankara, Bangalore. This is showing a superior oblique posterior tenectomy. Supratemporal incision is marked, and the conjunctiva is cut, and careful dissection of the tenons is made, and you first hook the superior rectus muscle. The superior rectus muscle is hooked and isolated, and underneath you can see the superior oblique which is hooked after carefully done. See, now the superior oblique has been hooked, and the tenons are separated. And after separating and isolating the superior oblique muscle, the anterior fibers are important because if anterior fibers are cut, it can result in intracranial torsion, and anterior fibers are left and the posterior part of the fibers are separated. See, the posterior fibers are separated and the posterior tenectomy is done. This is done commonly in case of aesotropia as well as exotropia due to superior oblique overaction. See, the tenotomy is done. And now the conjunctiva is closed. Silicone expanders, here also the amount of weakening can be altered by the length of expander. 4 to 7 millimeters, 240 as band is placed. The advantage is reversible and there is less chance of overcorrection. Superior oblique tuck is done in case of congenital esopalsy with a lax tendon. If you are very sure the tendon is very lax, you can do a superior oblique tuck and it corrects the V pattern because of the lax tendon. Coming to the management of V esotropia, we know that if it is due to inferior oblique overaction, you weaken it, and if there is no overaction, then you do a bimedial recession with infra placement. Inferior oblique weakening alone and will correct 15 to 25 prism diopters. Vertical shift will correct around 20 to 25. Superior oblique tuck 15 to 25 prism diopters, and it along with an inferior oblique weakening will correct around 40 to 50 prism diopters. And VXO also the same thing, vertical shifting and inferior oblique will correct 15 to 20 around, and it along both combined together will correct around 30 prism diopters. And aesotropia, if it is very less than 20 prism, better to leave it alone. If more than 40 prism, you can do a superior oblique weakening, and if there is no overaction, then you do a bimedial recession with a vertical offset. Vertical offset will correct 20 to 25 and tenotomies will correct around 30 to 40 prisms. And axotropy also same wise, and vertical shifting will correct around 15 to 20, while in case of superior oblique tenotomy is correct 30 to 40 prisms. Now the rare pattern strabismus management, Y pattern, here you can do a superior transposition of the lateral rectus, and X patterns, if no oblique overactions are there, you do a recession of the lateral rectus alone, and in lambda pattern you can weaken the superior oblique muscles. Complications of the pattern strabismus surgery as such, it can cause iatrogenic vertical and torsional strabismus and diplopia due to that. Persistence of overaction will be there sometimes. Esopalsy if you do a superior oblique weakening. Abnormal head posture you induce with due to the torsional strabismus, and anterior segment ischemia, and vertical can be multiple vertical muscles are involved. This is an algorithm showing the AV pattern what we have told. Thank you.
Thank you, Resmi.